The epithelial lesions of the breast are classified into benign lesions and malignant lesions. The benign category includes the non-proliferative changes, which includes cysts, fibrosis, and adenosis. Also, proliferative diseases without atypia, including the epithelial hyperplasia, papilloma, sclerosing adenosis, complex sclerosing lesion, and also the proliferative diseases with atypia, including the atypical ductal hyperplasia and the atypical lobular hyperplasia. While the malignant epithelial lesions include the non-invasive carcinoma, which is the DCIS, ductal carcinoma in situ, and LCIS, which is the lobular carcinoma in situ, and also the invasive carcinoma. The majority of the benign epithelial lesions of the breast are diagnosed incidentally during the mammographic screening. And the benign changes are divided into three main groups, as I said. The first one is the non-proliferative changes, including the cyst formation, the fibrosis, and the adenosis. And in this category, the lesions are not associated with an increased risk of breast cancer. بينما second category, which is called the proliferative disease without atypia, although this category is polyclonal hyperplasia, however, it's associated with 1.5 to 2-fold increased risk of breast cancer. Compare that with the third category, which is the proliferative disease with atypia, including the atypical ductal hyperplasia and the atypical lobular hyperplasia. Those lesions are monoclonal, which means that they are precancer, and they are associated with 4 to 5-fold increased risk of breast cancer in both breasts. The first group in the benign epithelial lesions is called non-proliferative breast changes, and this reflects that those lesions are non-proliferative, which means that they are lined by only single layer of luminal cells and a single layer of myoepithelial cells, so there is no epithelial proliferation. Those lesions are also called fibrocystic changes. So the morphologic patterns in these lesions include fibrosis and cyst formation. If you look down here, there are three principal morphologic patterns included in this category. The first one is the cyst formation, which is the most common. And those cysts, which means dilated spaces, are lined by a single layer of luminal cells that may undergo apocrine metaplasia, where the cells have abundant granular cytoplasm, apical snouts, enlarged nuclei, and prominent nucleoli. However, those cysts may rupture, and this will induce chronic inflammation and fibrosis in response to the spillage of the debris from the cyst content, and that's why they are called fibrocystic changes. Another morphologic change that included in this category is called adenosis, which means increased number of acini per lobule. This figure shows the histologic findings seen in cyst formation, which is one of the non-proliferative breast diseases or fibrocystic changes. As you can appreciate here, we have a cystically dilated duct or lobule, and it's lined by two layers. The innermost layer is a layer of cells that have abundant granular eosinophilic cytoplasm, apical snouts, enlarged nucleus, which is located basally here, and the prominent nucleoli resting on the myoepithelial layer. So this is what we call cyst formation. If this cyst ruptures, then it's gonna cause a spillage of the content into the adjacent tissue, inducing chronic inflammation and fibrosis. The second group in the benign epithelial lesions is called proliferative disease without atypia. So here we have variable degrees of epithelial proliferation, including the luminal cells and the myoepithelial cells, but they do not show cellular atypia. Those lesions are commonly detected as mammographic densities or calcifications, or even incidentally when you investigate for another lesion. As we said before, those lesions are polyclonal, so they are not monoclonal, and they are not associated with genetic changes. So those lesions are considered as predictors of risk, but unlikely to be a true precursor for carcinoma, and the presence of these lesions increases the risk for breast cancer by 1.5 to 2-fold increased risk of malignancy. This group includes epithelial hyperplasia, So in epithelial hyperplasia, the lumen of the duct or the lobule is filled with mixed population of luminal and myoepithelial cells, but without atypia. The second lesion is sclerosing adenosis. From the names, adenosis means that the number of the gland is increased, and sclerosing means that the stroma shows fibrosis or sclerosis that gonna distort and compress the glands. So sclerosing adenosis, you have proliferation of the glands and fibrosis. The third lesion, complex sclerosing lesion. Now the complex sclerosing lesion, in this lesion you have central area of sclerosis. And this area is composed of fibrosis and elastosis, with the ducts and the lobules radiating outward. The fourth change is called papilloma, and in papilloma you see finger-like projections or papillae with fibrovascular cores that are lined by luminal and myoepithelial cells without atypia. This figure shows the histologic findings in epithelial hyperplasia. As you can appreciate here, there is a proliferation in the cells within the acini or within the ducts, and those cells are composed of luminal cells and the myoepithelial cells. So it's a mixture of two types of cells but without atypia, سواء كان في lobules in the acini or in the ducts. This figure shows the histologic findings for another proliferative lesion without atypia, which is sclerosing adenosis. As you can appreciate here, there is increased number of the glands, but also the background stroma shows fibrosis or sclerosis, resulting in distortion and compression of the glands. So as you can see here, the number of the glands is increased, but also the stroma is sclerotic or fibrotic, so the shape of the glands became distorted, so they are irregular in shape or compressed or even like closed with a slit-like spaces. So this is what we call sclerosing adenosis, which is one of the proliferative lesions without atypia. Another proliferative lesion without atypia is called the intraductal papilloma. And from the name, here is a dilated duct which includes this proliferation. As you can see, we have fibrovascular cores forming finger-like projection or papillae into the lumen of this dilated duct, and all are lined by luminal epithelial cells and myoepithelial cells without showing any atypia. So this is a proliferative change without atypia. The third group in the benign epithelial lesions is called proliferative disease with atypia. So now we have proliferation of the luminal and the myoepithelial cells, but the cells showed atypia. And those lesions, as we said, are considered monoclonal or precancerous, associated with like 4 to 5 folds increase in malignancy in both breasts. This category includes atypical lobular hyperplasia, where the lesions resembles lobular carcinoma in situ, and atypical ductal hyperplasia, where the lesions resembles ductal carcinoma in situ. So what's the difference? The difference that those lesions have some of the histologic features that we use to diagnose the carcinoma in situ, but not all of them. So the atypical lobular hyperplasia show some of the features that we use to diagnose lobular carcinoma in situ, but not all of them. That's why we placed those lesions in this category. Same thing for the atypical ductal hyperplasia. So those lesions show some, but not all, of the histologic features that are required to diagnose ductal carcinoma in situ. Again, those lesions are monoclonal, precancerous, associated with moderate increased risk of carcinoma. This figure shows the histology of atypical ductal hyperplasia, which is one of the proliferative lesions with atypia. So as you can appreciate here, we have a cluster of ductular structures, and those ductular structures' lumens are filled with epithelial proliferation. But look at the epithelial cells. The nuclei are hyperchromatic, enlarged, and there is a pleomorphism, so the cells do not look alike. Each cell has its size and shape, and also the nuclei. So we have a pleomorphism and variation in the nuclear size and shape, and atypia with enlarged hyperchromatic nuclei. So here we have epithelial proliferation with atypia.